In this next section, we're going to continue to talk about some of the pathological conditions related to the reproductive system. Next, we're going to talk about some disorders of the testes and the scrotum, and we're going to start with the hydrocele. A hydrocele is an accumulation of the fluid, um, basically within the scrotum that is outside the testes. This can be either from a congenital defect, or in adults, it can be idiopathic, which includes inflammation, infection, trauma, or tumors. It causes the scrotum to be enlarged and transilluminant, which means you can kind of see through it almost. It is important to know that it is painless, and the scrotum does usually get larger as the day goes on. Diagnosis, again, is made by history and physical, and commonly an ultrasound. Normally, as far as treatment, the fluid will reabsorb by itself, but you may also need to try some scrotal elevation, sitz bath, or heat or cold application. If there is in the adults, you want the main way to remove that is by treating the underlying cause. If it is a congenital defect and it's caught early enough, surgery may also be indicated. Next, we're going to talk about testicular torsion. And this is where there is an abnormal rotation of the testes on the spermatic cord. It is most common in the up to the first year of life, and again common between the peak of puberty at ages 17 and 18. I've never seen it in children, but I have seen it in a 17 and 18-year-old. If it is not treated, it can lead to ischemia and necrosis. Again, this is another urological emergency, and your job is to basically identify it. It is most frequently caused after some type of trauma. The manifestations include sudden onset of severe testicular pain. They also may be nauseated, vomiting, lightheaded, dizzy, or have bloody semen. Diagnosis includes, again, the history and physical with a Doppler ultrasound and a scrotal ultrasound. And treatment to avoid complications should be done within 6 to 12 hours, which is obviously surgical intervention. The most important thing you would need to do is, if you were in the primary care office and you identified or had someone concerned with this, you would send them to the emergency room for evaluation. There are some disorders of pelvic support, and this happens as you get older, as the supportive structures, the muscles, the ligaments, and the fascia in women support the bladder, the uterus, and the rectum, and they often weaken with age, excessive stretching, obesity, trauma, or as hormones decrease in menopause. There are several categories of pelvic organ prolapse, and it is described by the site where the prolapse is visualized. We often think it's like we describe it normally, I think, at the bedside as like bladder prolapse or rectal prolapse. But that how I want you to think about them for the test and going forward is about the anterior compartment is normally the bladder, the posterior compartment is usually rectal, and the apical compartment is typically urine or uterus or cervical collapse. I will correct these in the PowerPoint when I'm all done posting this. So the clinical manifestations are normally they're often asymptomatic, but they may feel some pressure related to the prolapsed organs. The women may also experience some vaginal urinary or pressure when they're defecating or have some sexual dysfunction. There is no treatment, particularly if they're asymptomatic, but you may recommend Kegel exercises or avoid straining. There may be incontinence interventions that happen that include bladder training or protective garments, or there may be surgery indicated if needed. And again, if you saw this in primary care, you'd be referring them to gynecology for treatment and evaluation. Next, we're going to talk about a few menstrual disorders. First, we're going to talk about abnormal uterine bleeding. Menstrual abnormalities can be abnormalities in the cycle frequency, the blood loss volume, or the duration of flow. Abnormal uterine bleeding presents basically as vaginal bleeding from the uterus, but it can also include bleeding from the cervix, vaginal or vulva. And again, remember with the close proximity, you may need to think about urinary and GI sources of bleeding as well. There are overall, the menstrual cycle is typically, again, between 4 to 8 days long and can occur every 24 to 38 days. When you are comparing someone's menstrual cycle, remember you're comparing it to their baseline. Their baseline, and if you notice a change, is what you're going to compare it to. Not every person has the same cycle, so you're going to compare it against their baseline. Some menstrual disorders can be minor and easily treated, while others indicate that there's something more serious going on. And if you look, there is some revised terminology for abnormal uterine bleeding. Chronic means that it's been happening for 6 or more months, and acute means that there was one single episode. Heavy menstrual bleeding refers to interference with your life or activities of daily living. Intramenstrual bleeding is when there's random episodes of bleeding between your periods, and amenorrhea is when there's no menses at all. Cause is often based on age, and the causes are often very variable. Remember that bleeding in a postmenopausal woman is not usually a sign of something good. And the other thing you always want to do is when there is a change in the menstrual cycle, if they're at the point where it could be a consideration, you want to make sure that they are not pregnant. Amenorrhea is the absence of menstruation, which means it may never have occurred, or it may have occurred and not ceased and ceased. There is primary amenorrhea, which means they have not had their period by age 16. That can be caused by genetic or atomic abnormalities, and it can also be from hormone imbalances, pituitary gland imbalances, or from disorders of the hypothalamus. Secondary amenorrhea is when there are when you've gone 3 or months without your period if you have a normal menstrual cycle, and more than 6 months if you have an irregular cycle. Normal causes include pregnancy, menopause, or lactation, but there can also be pathological causes, which include hormone disorders, autoimmune disorders, or tumor. We're going to talk about the diagnosis and treatment altogether because they are somewhat similar. Dysmenorrhea is when there is such painful menstruation that it impairs your activities of daily living. This is from the excessive prostaglandin that is secreted that produces strong uterine contractions and blood vessel constriction, intensifying normal uterine ischemia or sloughing of the uterine lining. Diagnosis and treatment for both of these includes a history and physical, a pelvic ultrasound, hormone assessment, and possibly surgical intervention if needed. For dysmenorrhea, the treatment may include NSAIDs because they actually inhibit prostaglandin secretion, but for both disorders, it can include oral contraceptives. When we look at heavy and intermenstrual bleeding, there are several causes. There are structural causes and non-structural causes. And if you look on page 408 of your book, there is a summary. This picture also has a summary, but that is what I want you to focus on for here. If this happens during perimenopause, it can be normal, but it may also be related to polyps or fibroids. If this happens during menopause, it is definitely abnormal, and it can include uterine polyps or some type of malignant disorders or hormone disorders. But usually when you see bleeding in a postmenopausal woman, your first concern is always that they have some type of undiagnosed cancer. We look at premenstrual syndrome. This is the physical and emotional symptoms affecting women during their menstrual cycle. It is really not well understood, which I think is interesting. But what we do think is that during the luteal phase, estrogen and progesterone levels are normal, but for some reason, there is suspected abnormal neurotransmitter changes, particularly to serotonin. Clinical manifestations include the things that you may already know that include irritability, depression, mood swings, fatigue, headache, abnormal bloating, changes in the bowel pattern, joint pain, breast tenderness, weight gain, or sleep disorders. Diagnosis is usually made again by history and physical examination. You may do ultrasounds and other types of things like that, but mostly based on symptoms. Treatment includes hormone therapy and can also include diuretics, antidepressants, particularly SSRIs because it helps with the uptake of serotonin, lifestyle changes, or dietary changes. Next, we're going to talk about endometriosis, which is a disorder of the uterus. With this, there is a lesion growth and formation from the endometrial lining outside the uterus. The lesions are estrogen dependent and resist the effects of progesterone, but without an outlet, the blood is trapped and often irritates the surrounding tissue, causing pain, cysts, scarring, and adhesions, causing ovarian dysfunction and impaired fertility. The cause of this is actually unknown, but there are many risk factors that exist, including normal onset of menses, late menopause, nulliparity, heavy menstrual bleeding, a low BMI, being tall or over 68 inches, severe sexual or physical abuse. Clinical manifestations, again, can be very variable, but it can include dysmenorrhea, low back pain, bowel dysfunction, painful intercourse, infertility, urinary dysfunction, and pain during vaginal examinations. Diagnosis includes a history of physical examination and pelvic ultrasound. Treatments include analgesia, hormone therapy, and possibly a surgical intervention, including possible ablation. Next, we're going to talk about some disorders of the ovaries. First, we're going to talk about ovarian cyst. These are benign fluid-filled sacs on the ovary. They are either functional, that happen during normal physiological changes that a woman has over the course of her menstrual cycle, or they may possibly be something bad like a neoplasm. They're very common in women during childbearing years. There are three types. Follicular cyst. Instead of releasing an egg, the fluid stays in the follicle, and that is the most common kind. There are corpus luteum cysts, where there is inadequate development of the corpus luteum, and they are not particularly common. And there are dermoid cysts, which form from ovarian germ cells, which have the potential to become malignant. But again, once a month, you get a fluid-filled cyst that is functional and because of normal physiological events. Clinical manifestations can include abdominal pain and discomfort, abnormal bleeding, and just like with the men, there is such a thing as ovarian torsion. So if someone has sudden onset of pain, for instance, right lower quadrant pain in a female is very difficult to diagnose because if we think of all the organs that are there, it could be the ovaries, it could be the appendix, it could be the bowel. There are many things there. But again, if you suspect ovarian torsion, that is a surgical emergency as well. History includes, diagnosis and treatment includes a history and physical, assessing for pregnancy, a pelvic or transvaginal ultrasound, hormone markers, most resolve without any on their own. but they may consider surgical contraceptives or surgery if needed. Next, we're going to talk about polycystic ovary syndrome or PCOS. This is a common endocrine disorder that is characterized by functional ovarian hyperandrogenism and insulin-resistant hyperinsulinemia. You may have this or know friends who have it, but they have abnormal body and facial hair, acne, male pattern baldness, infrequent menses or anovulation, obesity, or they may have frequent ovarian cysts. Diagnosis and treatment is made by history and physical exam, hormone levels, including insulin levels, and ultrasound. Treatment includes weight loss, hormone therapy, can be oral contraceptives. Spironolactone is one thing that is used because it will lower the androgen levels. Another thing that is sometimes used is metformin. We're going to talk about some disorders of the breast as well. Benign breast masses are often detected by palpation or imaging. They are classified based on the type of breast tissue that they are. The clinical manifestations, you may palpate them or you may feel pain before or during the menstrual cycle. They often do vary with menstrual cycle as well, and the characteristics of the mass can be very variable. Given that these are benign, the diagnosis includes a history and physical and an ultrasound, and treatment largely revolves around treatment of any symptoms the woman might have. Inflammation, mastitis is inflammation of the breast tissue that's usually associated with an infection, particularly the causal bacteria is usually staph or strep, and they are usually lactating. Clinical manifestations include breast tenderness, breast lumps, pain while breastfeeding, flu-like symptoms, nipple discharge, or enlarged axillary nodes. Diagnosis and treatment again includes a history and physical, a culture if possible, antibiotics, adequate hydration, rest, analgesia, a supportive bra, heat or cold application, and mild expression of breast milk. Sometimes women can continue to breastfeed when they have mastitis, and sometimes they can't. It depends on their response to the antibiotic therapy and if the child is able to breastfeed during that time. That concludes the second portion, and we're going to pick up in just a minute with infections, STIs, and cancers of the reproductive tract.